So pulmonary ventilation is the physical movement of air in and out of the respiratory tract, and it provides alveolar ventilation. The movement of air occurs because of atmospheric pressure and the weight of air, and it has several important physiological effects. So we're going to have a look at those. So we have to learn about Boyle's law first. So this is one of the gas pressures and volume laws. So Boyle's law defines the relationship between gas pressure and volume. So in a contained gas, there are external forces, molecular forces, which forces the molecules closer together. And the movement of the gas molecules exerts a pressure on the container. If you want to have a look at a demonstration, go to this YouTube. So here we've got a container, and the black bits are the molecules of gas. And you can see if we have a container, if we make the container smaller, then there is more pressure because the molecules are closer together and they're causing more pressure. If you have a larger area, there is less pressure. So if you decrease the volume of the container, the collision between the molecules occurs more frequently, elevating the pressure of the gas. If you increase the volume, there are fewer collisions because there's more room, and it takes longer for the gas molecules to travel from one wall to another. As a result, the gas pressures inside the container decreases. So knowing this, we have to now transfer that knowledge into the physiology of air moving in and out of the lungs. So air flows from an area of high pressure to an area of lower pressure. Think of air escaping from a car tire when the puncture occurs. You've got a lot of pressure in the tire, and the air will leak out of the tire really rapidly until the pressure inside the tire is the same as atmospheric pressure. A respiratory cycle consists of one full inspiration, one inhalation, and one expiration or exhalation. Pulmonary ventilation causes volume changes that create changes in pressure, and the volume of the thoracic cavity changes with expansion or contraction of the diaphragm or the rib cage. So we're going to have a look at that now. So here we've got our spine, and what you can see there is that you've got the first and the last rib and the sternum attached. And you can see that the ribs and the sternum can move up and down as the diaphragm contracts. Here we've got the representation of the pleural cavity. You've got the left and right lung, the cardiac notch, and you've got the red line, which is representing the diaphragm. And here, when we're talking about P, we're talking about pressure. And here there's no air movement because P pressure is equal to the P pressure inside. So there's no need for air to move in or out of the lungs because it's the same pressure on the external environment as inside the lung. So no air movement occurs. However, if the person inhales, when they inhale, their diaphragm goes down, their rib cage goes up, and the area inside the thoracic cavity increases. So that means that the pressure inside the thoracic cavity decreases, and air, as we know, flows from a high pressure to a low pressure, so air will move from the atmosphere into the lungs. This is inhalation. The opposite happens with exhalation. Here the diaphragm relaxes and moves up, the rib cage moves down, and the surface inside the thoracic cavity decreases. And that means that the pressure inside the thoracic cavity is now greater than what it is outside in the atmosphere. And again, the same rule applies. The air will move from a high pressure to a low pressure. So now air moves out of the lungs and is expired or exhaled back out into the atmosphere. So when we look at the pressure, The pressure inside the lung is greater than outside, and air will move from high to low pressure. We also need to talk about compliance. So when we're talking about pulmonary ventilation, it's an indication of how much the lungs can actually stretch, the expandability. So if a person has low lung compliance, it means that they require greater force to be able to carry out pulmonary ventilation. High compliance means less force. And factors that affect compliance are the connective tissues of the lungs, the level of surfactant production, and the mobility of the rib cage. So if you have a person who has connective tissue disease of the lungs, they will require more force to move air in and out. If they have a low level of surfactant, again they will need more pressure, and if their rib cage is unable to move as much. So pressure changes during inhalation and exhalation can be measured inside and out or outside of the lung. So normal atmospheric pressure, 1 atm, 1 atmosphere, is equivalent to 760 millimeters of mercury. So the pressure of 1 atmosphere will raise a column of mercury 760 millimeters above sea level. The intrapulmonary pressure is also called the intra-alveolar pressure, and it's relative to the atmospheric pressure. In relaxed breathing, the difference between atmospheric pressure and the intrapulmonary pressure is small, about 1 millimeter of mercury on inhalation or 1 positive millimeter of mercury on exhalation. So not a lot of difference. With maximum intrapulmonary pressure, maximum straining, a dangerous activity, can increase the range from minus 30 millimeters to over 100 millimeters of mercury. So this straining can also increase blood pressure, and this straining is what can cause a rupture of some blood vessels. So intrapleural pressure is the pressure between the parietal and the visceral pleura. So we want the parietal and the visceral pleura to be a negative pressure so that the pleura are actually stuck together. So the average is -4 and the maximum is -18. So it remains below atmospheric pressure throughout the respiratory cycle, so the lungs stay outwards and attached to the visceral pleura, keeps the lungs open. A respiratory cycle is the cyclic changes in intrapleural pressure and operates the respiratory pump with the aid of the venous return to the heart. So we're going to go through some common terms in relation to pulmonary ventilation now. So tidal volume, also represented as VT, is the amount of air moved in and out of the lungs in a single respiratory cycle. Injury to the chest wall can cause what is known as a pneumothorax. Pneumo meaning air and thorax. So air is allowed to enter into the pleural cavity. So that means it's outside of the lung tissue and has leaked into the pleural cavity. There's also an injury called atelectasis, and this is caused when the lung collapses, and this can be the result of a pneumothorax. So in your laboratory this week, you'll have an opportunity to inflate a sheep's lung with the air hose, and you'll be able to see how much the lung will be able to inflate, and you'll also be able to inflict an injury on it and feel the air coming out of the lung against your hand. So what we're going to do now is just revise those pressures that we were talking about. So here we've got the diagram of the lungs and the diaphragm, the left and right pleural cavity, and you can see that we've got intrapulmonary pressure, and you've got intrapleural pressure, and you've got tidal volume. So the red line is the intrapulmonary pressure. That's the red line. And then you have intrapleural pressure, which is the blue line, and tidal volume. So you can see that there are changes in intrapulmonary pressure during a single respiratory cycle, and also changes in intrapleural pressure. And if we were to plot the tidal volume, or the amount of air moving in and out of the lungs, you would see that there is a correlation between changes in pressure between the intrapleural and intrapulmonary pressure. So respiratory muscles. The most important respiratory muscles are the diaphragm and the external intercostal muscles of the ribs. There are other muscles, and these are called the accessory muscles. If we were doing a physical examination, we would use our observation skills to see if the person was using any of their accessory muscles involved in respiration. So the mechanics of breathing. Inhalation is always active, and exhalation can be active, but is most likely to be passive. Muscles used during inhalation. You've got the diaphragm, the external intercostal muscles, and the accessory muscles which assist in elevating the ribs. So the sternocleidoid mastoid, the serratus anterior, the pectoralis minor, and the scalene muscles. So we're just going to have a look at those now. You can see here that the diaphragm moves down and the rib moves up. It's representing, they talk about it like a bucket handle. So during respiration, you've got that movement, and you've also got it being assisted by these muscles. So the sternocleidoid mastoid, which is coming off the sternum and the clavicular, and is of course joining onto the mastoid process in the skull. The scalene muscles there, the pectoralis, and of course the big one underneath the rib cage, which is the diaphragm, which looks like a parachute muscle. And remember, when the diaphragm contracts, it moves down. When it moves down, it increases the thoracic space, causing an increase in area and causing a decrease in pressure. And of course, air moves from the atmosphere into the lungs. Here we've got a diagram showing you the movement with inhalation, where we've got the ribs moving up, the diaphragm moving down. Muscles used in exhalation, the internal intercostal and the transverse thoracic muscles depress the ribs. The abdominal muscles compress the abdomen and force the diaphragm upwards. So here we have a diagram showing you again with exhalation. So with exhalation, the diaphragm moves upwards, decreasing the area of the thoracic cavity, forcing air to be under higher pressure, and the air in the lungs moves out into the environment. So modes of breathing. There are different patterns of breathing. There's quiet breathing or forced breathing. So quiet breathing is also known as neuropnea and involves active inhalation and passive exhalation. Diaphragmatic breathing or deep breathing is dominated by the diaphragm. So people who play wind musical instruments or are involved in singing are very familiar with diaphragmatic breathing. And the third type of breathing is coastal or shallow breathing, and it's dominantly movement of the rib cage. With pulmonary ventilation, you also have elastic rebound, where inhalation muscles relax and the elastic components of the muscle and the lungs recoil, returning the lungs and the alveoli to their original position. Forced breathing is known as hyperpnea, and it involves active inhalation and exhalation. It's assisted by the accessory muscles, and it has maximum levels. When maximum levels occur, it can result in exhaustion. Respiratory rates and volumes. Respiratory system adapts to changes in oxygen demands by varying the number of breaths per minute in the respiratory rate, and also the volume of air moved in and out in each breath. That's known as the tidal volume. So when we look at alveolar gas content, the alveolar contains less oxygen and more carbon dioxide than atmospheric air, which when you think about it, that's a bit strange, but when you think about it, it's because the air mixes with the exhaled air. Right, so when you breathe in and breathe out, there's always a mixing of the inhaled and the exhaled air. So it contains less oxygen and more carbon dioxide. So some terms that you might that you'll need to get to know. So you've got resting tidal volume. It's a normal respiratory cycle. The expiratory reserve volume is what is left in the lungs after normal exhalation. The residual volume, this is the amount after maximum breathing out, and minimum volume in a collapsed lung. And the inspiratory reserve volume is after normal inspiration. We can calculate respiratory capacities based on those volumes. So inspiratory capacity is the tidal volume plus the inspiratory reserve volume. The functional residual capacity, or the FRC, is the expiratory reserve volume plus the residual volume. Vital capacity is the expired reserve volume plus the tidal volume plus the inspiratory reserve volume. So that's the maximum capacity.